Hi everyone, today I will be providing a brief overview of my research project on Japanese mental health policy during the last 150 years. In this presentation, I will discuss the three different sections of my paper so you can better understand my topic. Throughout its modern history, Japan has walked the line between being a country fighting through economic and political challenges and also one that has created successful policy. My research looks at why Japan's mental health policy specifically has repeatedly failed to meet citizen needs. I cover three individual periods: the late 1800s to 1967, 1984 to 2013, and 2013 to present. These periods display changing attitudes towards mental health generally and towards policy initiatives. The thesis I developed about why mental health policy has failed is that the Japanese government has addressed it in a blanket manner, with wide recommendations and goals rather than changes on the ground. This approach, coupled with societal stigma, has created a culture where these issues have persisted. The first period I discussed, the late 1800s through 1967, cover Meiji laws and the war and post-war eras. Laws during this time were focused on keeping mental patients away from society through family caretaking or long admission to hospitals. Both of these practices left individuals with poor and untailored care. In 1900, the Home Custody Act of Mental Patients was enacted. The goal was to ensure that mental patients were not left homeless. However, this put a significant burden on families. The result was that mental patients were forced into prison-like conditions at home. The Japanese government imposed the Second Act in 1919. They recommended that all prefectures open up mental asylums. However, in the following 30 years, only 8 were opened. The lackluster response reflected the blanket approach and the lack of incentive for local officials to act if they had little information about mental health or funding. During wartime, in the hospitals that did exist, conditions were poor due to a lack of resources and a diversion of care to providers and other war-related postings. Mortality rates in mental asylums skyrocketed from 14% in 1943 to 41% in 1944 and 45. These conditions led the World Health Organization to studying the Japanese mental health care system in the 50s and 60s. In 1967, David Clark, a World Health Organization rep, called for Japan to switch to a community-based care approach. Yet, Japan responded that they had nothing to learn. After neglecting recommendations, Japan was suddenly faced with the Unitsoma hospital scandal in 1984, where a mental patient was killed due to maltreatment. This scandal, and the growing concern of suicide, sparked a series of policy initiatives in the second period. The goal of the mental health law, created in 1987, was to reverse immoral practices from the past. According to Minas and Lewis, scholars I reference, quote, voluntary admission was recommended as the norm. Also, only a designated psychiatrist who had completed training about human rights was permitted to treat involuntary patients. End quote. During this time, there were not systems in place to treat the rising issue of suicide. As shown above, suicide was extremely evident in the late 80s, early 90s, and 2000s. Scholars cite stressful employment situations, restructuring, and performance reviews as primary factors in this rise. In response, the MHLW included suicide prevention into the Healthy Japan 21 plan, which would allow them to create a national suicide prevention council with a budget. Their goal was to create local versions of these councils in every prefecture. The graph above shows the slow growth in the number of these councils across Japan. The Diet and MHLW then created two distinct initiatives that targeted mental health care and suicide prevention nationally. The Basic Act was a series of goals for suicide prevention, while the GPSP, the General Principles of Suicide Prevention Policy, promoted specific initiatives, as shown on the right. These policies were coupled with the Regional Healthcare Strategic Plan, which asked every prefecture to develop clear plans to address depression, schizophrenia, and suicide. Prefectures were required to create systems of education, patient outreach, rehabilitation, emergency care, with clear prevention targets and goals. These policies seemed promising, however, after studying their success, the consensus was that prefectures wanted to be perceived as successful, and their goals created a mirage of success. This brings us to the third period in my research, which is discussing the main modern challenge Japan is facing: youth suicide. Due to high pressure academics, cyberbullying, and COVID isolation, many Japanese youth have felt isolated. As a result, youth suicide rates have constantly increased since 2012. Youth specific mental health resources in Japan are severely limited, making the country under equipped to tackle this challenge. Despite this, in my research, I did find some silver linings. Research from 2024 on the Mental Health Supporter Training Program, a series of educational videos meant to reduce the stigma on mental health and teach the public about prevention, found that there were long-term positive effects on altering the perception of mental health for participants after watching these videos. While the Japanese mental health policy story is tainted with failure due to poor local implementation, stigma, and neglect of patient needs, it is important that Japan continue to implement successful strategies like the one I highlighted if they want to positively affect mental health outcomes in the future. Thank you very much for listening, and I hope you enjoyed, and I would be happy to answer any more questions.